Okay, I'm going to ask Dr. Iwan-Chinna to come up and introduce our next speaker. We're going to learn a little bit more about trauma-informed care.
Thank you, Kelly. It's great to be back in Eastland County, and it's great to be seeing so many familiar, friendly faces and new faces in the audience. I have to tell a little bit of a story before I introduce the next guest speaker, and that is regarding my own humility and about not being aware of trauma-informed care and ACEs, adverse childhood experiences. And it was about 3-4 years ago when two very astute medical students from Western University Health Science, College of Osteopathic Medicine, Northwest, wanted to meet with me and wanted to tell me about ACEs, adverse childhood experiences. And my eyes were opened. This is the very root of our social structure and our fabric. It is the very root of compassion in helping our patients in our communities that have been affected by trauma. And not one of us can ever say that we have not been affected somehow, whether it's family members, friends, ourselves. And trauma-informed care is something we need to embrace in the healthcare setting. So I first met the next speaker when I was an attending in the Samaritan Family Medicine residency clinic. And I was sitting there reviewing the notes that the resident had sent my way. And there was this wonderful, compassionate person sitting at the other computer. And that was our next guest speaker. And Jana is a licensed clinical social worker within Samaritan Health Services. She spent many years in the family medicine residency clinic helping teach the residents about trauma, about ACEs. And then we were lucky enough to have her transition to Samaritan Mental Health. She has been a willing participant for many years with our Delivery Systems Transformation Committee. And anytime Jana speaks, she is speaking from the heart. She is a very compassionate person and shows the passion for the human condition. And that's what we're all about. So it's my honor to introduce Jana Svoboda to you, that's going to talk to us about trauma-informed care and adverse childhood experiences, ACEs. Jana?
It's always a good thing, right, to start a speech with an apology. I have to make an apology. I spent my weekend in the ED with a kidney stone, and I'm still having a kidney stone, and so I'm a little loopy and distracted. Maybe I'll hide behind here so you don't see me squirm, but normally I can talk. I just may not be able to do so tonight. Also, time has become very squishy, so Lisa, will you tell me when I'm about 10 minutes in so I have an idea? Otherwise, I might just sit up here and talk forever. We'll see. Kidney stones, I cannot recommend them. It's like having a baby, but you don't get the baby. Right now, the pilot that I'm working on is on physician and provider wellness for our nurse practitioners and our PAs and our docs. And as part of that pilot, one of the things that we see is that when providers become burned out, there's a lot of changes in the healthcare system. You might have noticed that, right, in the last few years. And those can be really wearing on the provider, because most people who go into medicine do it because it's a calling, it's a vocation. It's not just a job. They go in it because they're compassionate people who really, really rely on human relationship and use that human relationship to do miracles in people's lives. As things have changed rapidly, it's become a little more burdensome for them to spend the time they'd like to with their patients. And that can make it tricky to keep that empathy and that compassion up. It's not that it's not there, but it can get hidden sometimes by the demands of the job. And so helping them reconnect with their empathy has been one way to reduce burnout in the patients. One way that we help them connect with their empathy is to help them remember that every single person that they see has a story. Now we're going to see if I can handle technology. I'm not so sure. Let's see. Nope, that's not it. Let's try that one. Yay. Okay. Dr. Osler is one of my favorite people to quote when I talk about medicine, because he was the epitome of compassion in care. And he talks about how it doesn't matter how you care for the patient until you're caring for the patient, if that makes sense. That a patient isn't going to care about what you have to say until they know that they've been heard and seen. When medicine is working with an individual, they are working with the whole story of that individual, not just what happened to them in that moment. And what we found out is that a person who's been impacted by trauma, that trauma history is coming in with them into the examining room. It's coming into the doctor-patient relationship. Sometimes it's what's keeping them out of the doctor-patient relationship. They're not even showing up. We'll talk a little bit more about that as we go along. Oh, it's going to do fancy things. All right, I wasn't expecting that. All right, so you don't need the overview. I'm going to just whip through that part. Trauma, I think you all know what it is, but it's any sort of deeply distressing event that causes the brain to reorganize in the hopes that it will be prepared should such a thing happen again. So let me give you an example of one thing that would be a trauma. If you're driving down the street and you're getting ready to turn right, and all of a sudden, from nowhere, somebody comes out and nearly hits you. What happens in your body? This is the interactive part, so you have to play along. What happens in your body? Adrenaline, right? Cortisol, all kinds of little chemical cascades. Your internal fire alarm is going to go out and flood you with some chemicals. And how's that going to show up? Increased breathing, right? What's your face going to look like? Flushed? Flushed? Yes. Okay, red. What else? Yep, you're going to sweat. Your eyes are going to get really big, right? Your muscles are going to get tense. Why is that all happening? Why are your eyes getting big? Say again? So you can see better, right? To take in more of your visual field, right? Because your brain wants to know what's going on here. It's going to be looking for escape routes. It's going to be looking for clues as to what's going to happen next. And that stuff gets cemented in your brain. It's very interesting that when we're exposed to trauma, our brain makes a nice file of it. And it makes these files through little actual protein chains inside of your brain because it wants a quick connection to those should you come into this problem again. What are our big ways that we deal with trauma? What are our 3 most common trauma responses? You've heard these before. When we get faced with a huge stressor, we either blank, blank, or blank. Fight, flight, or freeze, right? A lot of people forget that last one. So think about freezing like this. Freezing is what we call a benign, this is like fancy words, a benign catatonic response. It means we're basically going away. We're going away. Have you ever had a deer stop in your headlights? Literally freeze in your headlights? They are gone. When they're doing that, they will stand in front of your car. You've got this big, huge vehicle. You can honk, but for a few seconds, maybe even a couple of minutes, they go nowhere. They just stare at you. And it's because they're actually not present. Why aren't they present? Because if you're unconscious when you're about to be pummeled by a 2,000-pound machine, it hurts less, right? So our freeze response is a trauma response. It's a way to escape the threat of the moment in a benign way, meaning also if we're still and we're being attacked by a predator, right, they may be less likely to eat us. They may not notice us, or they may think we're dead, in which case maybe we're diseased and they don't want anything to do with us. So freeze is a really effective response. The other 2, flight and fight, are more adrenaline-based response, right, to prepare us to escape the danger. Now, what does this have to do with trauma? Well, as I said before, traumatic events get encoded in our body. I think maybe there's going to be a story next, but we'll find out. Okay, it's all going to loop back and make sense at some future point, trust me. Okay, so trauma will affect you in different ways depending on different things. It affects you depending on when it happened to you. So if you were traumatized as a very young kid, that trauma gets embedded in a body that doesn't have a lot of resources available to it. If you were, for example, pre-verbal, then you may not have words to use to think about and process the trauma. If it happens when you were so young that you didn't have things like a cell phone or a credit card, your escape routes were really, really narrowed and you were dependent on other people for those, so a kind of a helplessness can come in. So when trauma gets re-triggered in your life, you can go back to those developmental stages in your response. Resources that are there or that we just don't see as being there make a lot of difference. So when we heard from Patty earlier, she described how they made resources available and the environment available in such a way that people perceived safety locking those doors. That's that perception of safety. Getting, whenever possible, the uniforms out of the room during the time that there's tender conversation is a way to increase the sense of perceived safety, unless the person perceives it as more safe to have someone in a uniform there. So resources that are there or we think are there. Previous trauma affects how we deal with trauma, because things that might not be scary for another person might be really scary to us because of the developmental stage when that first thing happened. So our response makes it more traumatizing now. And then things like learning. How did our family respond to trauma? How was it handled the first time we were in a trauma? Was there corrective healing experiences afterwards? Patty's job is to provide a corrective healing experience for people in the ED or in an office where they're talking about the trauma, but there's someone there to listen and to keep them safe and to hold their story for them in a compassionate way. And then there's genetic variability. This is a whole long story I could go into, but just trust me on this one, and I'll give you the resources if you want to look it up later. About 13 to 18% of us are just more hypervigilant than other people. It can be the result of early trauma, but usually it's just kind of a different variable in our genetic makeup. And if you think about a cob of corn, each cob of corn has 60 to 100 kernels on it. Every single one of those kernels is capable of making a whole nother plant with a whole bunch of other cobs of corn. But they're not all the same, even if they're coming from the very same seed. So you've got some seeds that are going to grow if it's really, really cold that summer, and some that will grow if it's a hot summer, and some if it's a wet summer, and some if it's a dry, and blah, blah, blah. And you need all those so that sometimes we'll have corn. Well, anxiety and a higher hypervigilance, the canary in the coal mine people, if that makes sense to you, they have a role for the tribe, if you think about it, in keeping the rest of us safe, because they're the ones that are going to worry, and they're the ones going to not take risks, and they're going to say, let's stay inside where it's safe. So if you imagine we're all in a cave 100 years ago, we better make that a few thousand years ago. I told you I'm a little loopy. So we're all in this cave together, there's 10 of us, there's enough food for 5 of us, it's going to run out in a month or so, but outside of our cave are big scary monsters. You got a certain percentage of people, maybe more like 10% of people, that have a pretty low reactivity level. They're just calm, cool, and collected. And then you've got this 15% or so that are really kind of like, it's dangerous out there, I'm not going anywhere. But they're also the ones that say, Lisa, it doesn't look like you have much to eat tonight, I'll share my roll with you. So these anxious people have this role in keeping everybody safe. And you can see how over time that's good for everybody. It's not so much fun for the anxious person, but it's good for the crowd. Okay? So I'm going to tell you a little story about a trauma that isn't going to seem like much of a trauma, probably at the time. This is a teaching story that Tom Rutledge, another social worker, tells, and he has permission from the patient to tell this story. A woman came to see him for therapy, this was many, many years ago, because she was scared to go inside of an airport. Now what's interesting is she was not scared to fly, she was scared to be inside of an airport. And what was scary about being inside of the airport is there might be birds inside of an airport. You know how sparrows fly around in the rafters? She had noticed this the first time a few years ago when she got on a flight and, went to the airport, and as she was sitting, a bird started flying around, and she got a really strong panicky feeling. And it went into a full-blown panic attack. She had no idea why this was happening, but it happened. Then she noticed the next time she went into Costco and saw a bird, started getting that hyperventilation, worried she was going to have a panic attack, couldn't stand being in the Costco, so she left the Costco. Doesn't go to Kmart anymore, can't bear it. She didn't know why this was happening. Well, zip zap, thanks to the miracles of cognitive behavioral therapy, 8 sessions, bang, she's fine, she gets on the plane. This was important to her because she had an elderly mother who she hadn't visited for 5 or 6 years. And she told her mom she was super busy, she said, work, the kids, blah, blah, blah. But really it was because she couldn't get in an airport. And she was too embarrassed to say, I'm afraid of the birds in the airport. And interestingly enough, she's not afraid of birds. She had no problem with birds in general. It's just birds in airports, or Costco's, or Kmart's. So she goes to visit her mom after her successful therapy, finally tells mom this story. And her mom says, oh, sugar, I think I know what that's about. When you were just a little bitty baby, I was cleaning out the flue in the chimney, and I opened it, and all these birds flew out. And they just started flying around the room, and I started screaming so loud. Your dad came in from the fields, and I screamed for probably 30 or 40 minutes, and he's comforting me, and I just could not calm down. And then about an hour later, we found you, and you were under the couch just sucking your little thumb. Okay, birds in the house are not dangerous, right? But if you're a baby and your caregivers are not available to you and you're very, very frightened, that's dangerous. If there's danger about and nobody is helping you and you have no way to locomote yourself out of the situation, you can't call somebody in to help you, that's really dangerous. So in her brain, that got cemented in. Just like if we were turning that corner in the car, whatever was going on around us might have gotten cemented in. If we turned that corner and we got hit and it was a beautiful day and we weren't really paying attention to what was going on around us, our brain was paying attention. So the next time, let's say that happened to us and we're safe, nothing terrible happened, maybe we broke something, but we're recovered. Next time we're in Fred Meyer's and that Taylor Swift song comes on, suddenly we're underneath a clothing rack and we don't know why. And it turns out that maybe that song was playing when we got hit. Does this make sense, how your brain would file all of that away? Okay, 10 minutes, thanks. Oh, she said that sternly too. Okay. Trauma is really, really common. That's why we want to look at it. In fact, there is a mandate for agencies such as IHN-CCO to look at the effects of trauma and figure out how they're going to deal with it. Because it is so common, because it affects how people access care and how they follow up on their care and on their health in general. This chart here is from a calling program. I don't know if any of you got this phone call from the IHN-CCO, where they went through the ACEs tests with people. They asked hundreds of health-related questions, but they also asked the ACE. And if you can imagine, some people probably weren't that comfortable describing or answering a question to a telephone person about whether or not they've been sexually assaulted or had a parent who beat them. I think these numbers are really low. But 1 out of 3 of us have had at least one trauma, according to that particular study. 8% of our population has had 8 or more traumas happen to them. And there is an effect that goes up geometrically the more traumas that you have had. If you have had, and these are studying only traumas that happened to somebody 18 years or younger. If you had 4 traumas by the time you were 18, things like your parents divorcing, which may not seem traumatic, but it is a real disruption in a child's life to have things be one way and suddenly caregivers are different or one of them is not there. Physical or sexual violence, being a witness to physical or sexual violence, it doesn't even have to happen to you. It can happen to somebody and you're there. 4 or more, and your health risks go through the roof. Increase in diabetes, increased rate of lung cancer, certainly an increase in depression, suicide, anxiety, things that you wouldn't even guess would be related. Autoimmune diseases such as lupus go up. Now, obviously there might be some predisposing genetic conditions that account for part of this, but part of it has to do with the health behaviors that people adopt when they've been highly traumatized. They self-soothe in ways that aren't really good for the body. Can you think of a couple of ways that might be? Drinking and smoking, right, are the 2 big ones that tend to really impact health. With increasing mental illness, which can result from trauma, although again, there usually needs to be that predisposing genetic factor. Take a guess, how many people with schizophrenia smoke cigarettes or are addicted to nicotine? Over 90%. Over 90%. That's amazing, isn't it? It's a self-soothing behavior. It helps people with schizophrenia focus. It relaxes smooth muscles so they can go to the bathroom. It does all kinds of things. But that's a really high number, so you can imagine that those health risks go up. But even with lesser impacting diseases, like anxiety or depression, you will also see those increases in smoking, increases in drinking. You will see more sedentary behaviors. You'll see a lot of avoidant behaviors, which have a cost over time. Sexual assault, these are again from that Oregon study, 1 in 6 women reported a sexual assault sometime during their lifetime. And again, that figure is probably really, really low. I have heard the 1 in 6 for men, but I am really of the mind, having done sexual assault counseling back in the day, that men way underreport and that it happens just as often to men as it does to women. So we know it's underreported. Why is trauma-informed care important? Because here's the definition of it. It realizes the impact of trauma and understands the ways to recover. It recognizes this is what we want to do. Signs and symptoms of trauma in clients, families, staff. It responds by integrating the way we do care to reduce barriers, to increase compassion, to increase a sense of safety, and it seeks to actively resist re-traumatization. How do you think medical care could re-traumatize a person? It's probably really easier if there were just like 6 of you, right? Instead of me asking a giant room. Go ahead, Patty. Having to repeat the story can be re-traumatizing, and often the way we repeat the story can be re-traumatizing because usually our brains organize this material as they are able. They disclose as they are able, but when you're in a crime situation especially, you're asked to provide lots and lots of details over and over and over again, and that is re-traumatizing for people, and often you're asked to do it with someone where you sense that you have very little control over the course of the conversation, which is why your project is so important, right? It could be re-traumatizing in other ways though as well. I'll get to those in just a minute. People who have a history of trauma, they get more sick more often. We already talked a little bit about that. They have trouble accessing and following through with medical care. They don't show up. They make an appointment and cancel at the last minute. They make an appointment but don't tell the whole story. They make an appointment, they get the medications and then don't take the medications because there's trust issues or other barriers. And they die younger. An average of 20 years reduction in lifespan if you have an ACE score of 4 or more. Now, I tell you this, and it always worries me to tell people this, because in the back of the room I have some ACE questionnaires, and there's going to be a lot of you that score 4 or more. And I want you to know the most important take-home message from this is trauma happens and recovery is possible. So if you read that figure, what that means is unaddressed trauma, unsupported systems. But if you're aware of your trauma, you understand the reasons for some of your behaviors, and then you get some support around helping that, recovery is not only possible, it's probable. Many, many different ways that affects behavior. We've already talked about those. So obesity, diabetes, depression, suicide attempts, sexually transmitted diseases. You think, well, why would that be connected to trauma? Well, the obvious reason could be the result of the trauma. But sometimes people try to create their own corrective healing experiences by engaging in sex as a way of feeling validated, cared for, whatever. So there might be unsafe sexual activity. Heart disease, cancer, stroke, you name it, it brings it up. How does it present in people when they are being triggered? It changes the mood, but that can show up in different ways depending on which of those 3 stress responses they're more likely to go to. So a person who is under stress can look extremely agitated. A lot of times they can look, and this is surprising to people, really, really angry. But if you think about it, anger feels like a much less vulnerable emotion, right? So if you have a person in your life who is really mad a lot, or if you're a doctor and they're in your office and they're really, really crabby, you might just assume that that's their defender showing up because they're feeling threatened, rather than they're just a jerk. Okay? Agitation, irritability, flatness, there's that freeze response. So some people, you'll see this oftentimes after there's been something terrible happen to someone in the news, and the family responds. So let's say, especially in murder cases, you'll hear this a lot. People say, well, she didn't look that upset. She should have been much more upset. She must have been the one who did it, right? Not realizing that some people's response to trauma is to go completely flat. And I don't know, are there any nervous laughers out here? I worked with a nurse one time that was a real nervous laugher, which was a problem for being a nurse. So the more bloody and disgusting the wound was, the more likely she was to start laughing hysterically. Yeah. People who've had trauma often ask a lot of questions if they're not shut down. They want lots and lots of information. They want lots and lots of reassurance, because what does anxiety want? It wants predictability. It wants to know what's going to happen next. That's just a slide to show you that whole body is connected, and a big take home for you. Your body and your brain are not born in different areas. They're all in the same vehicle, So anything that affects your body is affecting your personality and your mood, and anything that's affecting your personality, mood, and brain is affecting your body. So we don't have, I don't think, mental illnesses and physical illnesses. We have illnesses. And a person who's having a lot of symptoms, although they may not have a disease process going on that we can easily pinpoint, does not mean that they're not having signs and symptoms of a disease process. That may be stress-related. Here's some common things that show up in the doctor's office that tend to be, doesn't mean they're always, but tend to be trauma-related. Pelvic pain, severe persistent pelvic pain, erectile dysfunction, TMJ, that jaw-clenching stuff, neck, back, and other problems with their bones and their muscles. Lots and lots of GI stuff. Anybody know why that is? Did you know your gut is the second brain? Have you heard that before? 30% of your neurotransmitters are being manufactured in your gut, so it's the first thing to go when you're under stress. So a lot of people know that about themselves. They know that if they've got something really big about to go down, that they get a little bit of nausea or they get diarrhea. And in fact, Barbara Streisand says she throws up before every single performance, which is part of why she doesn't perform in public that often. But she says every single time she has to throw up, and then she feels better because she's releasing some of those stress-related hormones. Chronic pain, sleep disturbances, and fatigue. This is a picture of my dad. My dad had medical trauma. He was born during the Dust Bowl era, and the time where they had to stuff all the cracks in the house with wet cloths, and his crib had a wet cloth over it because the dust was so bad. He ended up getting osteomyelitis as an infant from the dust and what they called back then Dust Bowl pneumonia. He spent the majority of his childhood in and out of hospitals. In fact, when he was 6 and 7, his entire 6th and 7th year were in a hospital. He had over 80 operations. And the operations were pretty grim. They would open up his marrow, scrape it out, repair. As a result, he didn't really like hospitals very much. Not a big surprise, right? So from the time that I was born until he was 64, he did not go to a doctor at all. Because from his body experience, going to a doctor meant pain and trauma. When he was 64, he had a pretty sizable skin cancer on his arm that I felt like, even though I'm not a doctor, I knew that was skin cancer. And he was like, oh, it'll heal. And I was like, it's not healing. Then the next time I see him, it's worse. And I was like, you got to get that taken care of. Oh, it's nothing. I don't need to worry about that. So I did what any annoying daughter would do. I made an appointment for him with a dermatologist. I told him we were going out for coffee. And then he said, why the hell are we here? And he said, just shut up. And he saw the doctor. This doc had natural trauma-informed care techniques. He talked to him about the weather, about fishing. He talked about everything but health. He said, oh yeah, that is a skin cancer. Here's what we're going to do about it, da-da-da-da. And it turned out so well that after that was taken care of, my dad said, you know, I haven't had a checkup for a long time. I should go get a good checkup. And from then on, he had no problem going back to the doctor. He needed to have that corrective healing experience where he had some control and where he had a good outcome. And it can be really, really little things that can make a difference in trauma-informed care. It can be things like having a human being, when possible, answer the phone instead of something you have to route through. Like having somebody warmly greet you when you come in for your care. Like, I'll tell you my best doctor's appointment ever. I gave a talk at a youth shelter that will go unnamed, but it's not their fault. This stuff happens, right? I gave a couple of hours of a workshop there, maybe 4 or 5 hours. And when I left, one of the staff members took me aside and said, when you get home, bathe really well. We have scabies like mad here right now. So I went home and itched like crazy, right? And then the next day, oddly enough, I had a funny little rash where I had itched and itched and itched. And so I called my husband. I'm at work, and I say, I'm worried I have scabies. And he said, do not even come home. You go right to the doctor. So I call the doctor. I go see him, Bruce Byron, great guy. I come in, and he, do you mind if I touch your hand? Would that be okay? Oh, yeah. So he says, let me look at that. And he's looking at it. Well, first he's looking like this, and he says, okay, let me see. Yeah, there's a little redness there. But you know what? I'm really sure this isn't scabies. And I said, why do you say that? He said, because I wouldn't be touching you. It was a 2-minute appointment, but I felt so cared for. I felt reaffirmed. He didn't make fun of my being anxious about it. And that just little bit of safe human touch was really, really reassuring. So trauma-informed care doesn't have to be really fancy. It's seeing the human in the other human. It's understanding that some of their responses, like anxiety, like anger, like flatness, might just be their defender trying to take care of them. It's making the barriers as low as possible to getting them in to the office. And then making sure that there's a follow-up later, that they know you're glad you were there. You know, even if a little summary at the end saying, you know, I'm glad you showed up. I know it's not fun coming to the doctor's office, or I know it can be really hard for you sometimes. That was really brave of you, it's great. You know, so some kind of reinforcement, some kind of human compassion, and any kind of personal caring. Friendly, warm, inviting, having some self-soothing tools available to people, having an escape route available to people, all these things are really important. And trauma really, really likes predictability. Anxiety likes predictability. So along the way, when you're seeing the doctor's office, and if you are a person with trauma, ask for this if it's not being offered. You want to know what's going to happen next. What's going to happen in 2 minutes and 5 minutes. And for the most part, you're going to get those answers, and it's going to calm you down. Your brain doesn't necessarily have to like what's going to happen next. It just wants to know what's going to happen next. These are really for docs, so I'm going to skip this for you all, but you're welcome to ask me things later if you like. If you are the person and you are distressed, oh, right. Yeah. What's this thing? Okay, I feel like I'm such a yeller. Like, why would you need that? Okay, if you are distressed, it's nice to have some fidget toys available, some kind of distractions. For example, a lot of people have trauma in the dentist office. A lot of women have trauma getting a pelvic exam. Having headphones with some nice music playing helps them go into that freeze response in a way that's a little more helpful. It distracts, gives the brain something to do. Using imagery, reflecting distress, it's really important for us to be validated when we're experiencing a negative emotion. Just to have somebody say, you know, you seem really angry right now, or you seem really sad, or this is scary for you, isn't it? Can be enough right there just to calm us down, to bring us down. There is a whole list of tools and tips for you in the back that I'll be happy to share with you in a few minutes. And you can offer an acceptable reframe. An acceptable reframe just means a different way of thinking about it that's acceptable for the person. Do any of you remember that guy, the really annoying guy on Saturday Night Live, Stuart Smiley? And he would do these positive affirmations. His positive affirmation was, I'm beautiful and everybody loves me, and I can't remember what the other thing is. Those kind of affirmations don't work so well for me because I don't know that we could believe them. So something believable is nice. Like if somebody's getting ready to give you a shot, you say, yep, it's gonna sting. It's not gonna be as bad as a bee sting. That gives them something to compare it to. It gives them a realistic idea of what's gonna happen. It gives them some predictability, as opposed to them saying, this isn't gonna hurt, you're a big girl, deal with it, right? Which would not really, you know, it's gonna raise your level of anxiety. So reflect the distress and then offer an acceptable reframe, a different way of thinking about it. You're right, it is scary to get a shot, and yet getting the shot is gonna keep you from getting the flu, which, trust me, that's a lot scarier after 3 days on a toilet. Okay. Patient education, we use the ACE screens. Not all doc offices use this. I'm trying to encourage more to do it because, interestingly enough, the research shows that people just taking the ACE score reduces some of their health risks, just taking it. And I think that has to do with that validation that we were talking about before. That if you can start putting together, oh, that's why I do this. I get anxious at the doctor's office because I had these other experiences that were intrusive, that I couldn't control. And now my brain can separate out that this is a way I take care of myself as opposed to it going instantly to something bad's gonna happen. So taking an ACE screen either in or out of your doctor's office, understanding the impacts of stress, of trauma on the body, getting a resource list of where you can go for additional help, that should also be in the back. Pre-planning if something triggering is going on, if you're getting ready to do something that you know is going to be hard. So for example, what kind of things do you think would be hard for a person with a history of physical or sexual abuse? Pelvic exams, obviously. Prostate exams, obviously. Dental procedures, a lot of people don't think about that. Sedation, being knocked out, can be really, really frightening for people. So understanding that these could be potentially triggering, going through the verbal recognition that, boy, there's a difference between having somebody steal your wallet and donating to charity. That's kind of what I want you to think about here. You're looking at it like, what does she mean by that? But there's a difference between somebody coming into your body and hurting you and you willfully giving your body. There's a difference between having somebody stab you with a knife and getting a vaccine. Okay? So having that conscious reminder to yourself that these are separate experiences and you're safe and you're with safe people can make a big difference. Your goal is to provide, like Patty does, a corrective healing experience. Here it is, the trauma is being re-triggered again, but this time there's a different outcome because now you know you have resources, or now there's a compassionate person assisting you, or now your symptoms are being validated as a reasonable response to something terrible that happened a while ago. Here's some ways to regulate when you're triggered. First one that we often have people do is just to get present in the here and now. So I'll give you, I think we've got a couple of minutes left, so I'm going to have you do a couple of these things. Right here, right now, I just want you to notice, as soon as I shut up, what you can hear. What do you hear? Air conditioning. Can you hear anything else? Paper scratching? Kids' voices. Ah, good hearing. Okay. So that's what's happening right here and right now in this room. When we're in trauma, we're not right here and right now in this room. We're way back in the yonder, when whatever was happening for us. Reminding our body where we are right here and right now will calm us down. Use some distraction. This is why they have those beautiful pictures above the dental chair and above the examination table. Other ways to use distraction or to count the tiles in the ceiling or count the number of things that you can see with your eyes that are blue. You're just trying to get the brain to shift some of its resources. If you think about your brain as having, I mean, you all know this, higher functions and lower functions, right? And the lower functions are to keep you doing things like breathing, keep your blood pressure where it's supposed to be. Your higher functions are about critical thinking, about organizing data, about problem solving. And then in the middle, you got all those emotional reactions, right? The emotional reactions are tied very closely to action resources in the brain so that you can move quickly. When you're all in the emotional brain, some people call it the lizard brain or the monkey mind. When you're all in the monkey mind, those upper resources are not available to you. So if you think of it like a power plant, it's like all the light, all the energy is going to the middle, nothing up top. You can reactivate what's on top by using it. So you want to access your Spock brain. You want to think about things like, okay, what's 47 times 2 minus 14? That's about all the math it takes to get my math brain going, because if I go beyond that, I'm just going into freeze. But you can do things like trying to recall the dates of everybody's birthday in your family. You can do, I mean, if you have the time for this, you can do those puzzles that I always mispronounce. Sudoku, I don't know, that puzzle. Crossword puzzles. You can imagine or do a Deschamps smile. Anybody know what that is? Deschamps was this doctor who back in the late 1800s, early 1900s, can't quite remember, when they did teaching by taking the teacher to different towns and having them present in an auditorium like this. So they would teach you how to do an appendectomy. Well, maybe not that one, because you really want the person to need an appendectomy. But, you know, maybe to do some kind of a surgical procedure with everybody in the audience watching on. Or they would describe to you, you know, this is what, what's the real name for leprosy? Because it's not coming. Hansen's disease. This is what Hansen's disease looks like. Look at the person's fingers. Well, what Deschamps would do is he would bring an itinerant person from the street in. He would offer them a meal in exchange for their participating. He would wire them up with electrodes to their face. And then he would ask them how they were feeling. Now remember, they're in front of like 100 doctors on a stage with electrodes on their head. And guess what they would say? I feel really nervous. And then he would hit a little button, and they'd go like this. And he would say, how are you feeling? He said, I feel good. Why? I feel pleasant. Do you know why? I have no idea, right? I'm not doing a very good Deschamps smile because I have this little twinge. But do you know what a Deschamps smile is? Full-on eyes, mouth, smile. That particular face is completely incompatible with fear, with anger, with anxiety. Hardware informs the software and vice versa. If you smile like that, your body thinks you're safe. So if you're really, really anxious, you can either imagine or actually do that smile, and it will calm your body down. You can also imagine or actually do some poses that are only really what you do if you're not really freaked out. some kind of vulnerable, relaxed, ultra chill poses. And those will, again, tell your body, I must be safe. What do we do when we're really stressed often with our bodies? Yeah, we like protect our little hearts, we tense up, we curl in, and it's a feedback loop telling our bodies we're not safe, we're not safe, we're not safe. So changing that position can reduce what's happening for the body. Okay, when you see that, how does it feel in your body when you see that face? And this really does work. You should try it sometime. So next time you're really stressed out, you're really upset at someone, try doing a little math, a little algebra in your brain. Try doing a Deschamps smile. Try rearranging your body in the position of somebody who's really chill. Try doing a crossword puzzle or something else that will activate those higher resources, and your body will calm down. If you do decide to take the ACE study and something on there alarms you, you can find good peer support groups on the web, but I would encourage you to talk to your doctor about it too. A lot of people think, well, my doc doesn't want to hear that stuff, they just want to hear about my toenail fungus or whatever, and that's not true. Your doc wants to treat you as, or your nurse or your PA, as an entire human being, and they'll have a lot better chance of doing it well if they know who you are and what's happening for you. And then when stuff comes up that, like, they say, you haven't had a pap smear for 6 years, you haven't had your prostate tested in 12 years, even though you had that high PSA, now they understand why, and they can approach it in a different way that'll help you get the care that you need. All right, I hope this made a modicum of sense to you, but if not, I'll take a few questions. Or stunned silence, either one.
As Jana mentioned, there are some resources back there on the table, the ACEs questionnaire that she referred to several times in her presentation, as well as a toolbox for how to deal with stress and other anxiety. You guys can pick some up on the way out if you're interested.
Okay. So nothing from questions? Okay, you're welcome.